Hey everyone, welcome to Unit 6. In Unit 6, we covered schizophrenia and other psychoses. It covers chapter 31, which is actually not a very long chapter, and it's pretty well written. We're going to flip to actually the book in a little bit of this to show you where some of the things are in the book. So psychosis, the inability to recognize what is real, right? You can't relate to others, you can't cope with others' demands because you don't know what is really happening in the world around you. Most common is schizophrenia. We see some of the other ones, and we touch base on those briefly, but they are super minor. Just like everything else, there's a continuum, right? You can be highly adaptive and function really well, or you can be maladaptive. Although schizophrenia is a very serious disorder, many people can have mild cases and can learn to function appropriately. Right? Find the TikTok guy who's a kindergarten teacher with schizophrenia. He is coping effectively in society. He's taking his meds. He has a support system. Other people are not as lucky. So in childhood, right? The biggest things we need to remember are the risk factors, genetic influence. We have to assess for family history of schizophrenia. It is so important when symptoms occur. Complications during pregnancy or birth, right? Influenza during the second trimester. That leads to an increased risk in that child later in life having schizophrenia. Biochemical imbalances, right? Dopamine and environmental factors, stress and trauma can cause psychosis. In adolescence, right, your normal teen is in contact with reality. They know what is going on around them. They know who they are. With an adolescent who's struggling with psychosis, you see poor hygiene, strange speech, social withdrawal, odd behaviors, bizarre thoughts and beliefs, and unusual superstitions, right? Not too different than the adult. In adulthood, the acute onset of symptoms of schizophrenia will occur most often in men in their middle 20s and women in their late 20s. If you have a better work history, you're doing better in school, you have better social supports, you're more likely to have a mild case of schizophrenia, or even if it is a more severe case, to be able to cope better with it because you have those supports. In older adulthood, you hardly ever get schizophrenia diagnosed in an older adult, right? If you have an acute onset of any type of psychotic behavior in an elderly, you have to investigate it. Medications, steroids can cause psychosis, especially in an elderly. UTIs can cause strange behavior in the elderly. So we need to make sure we're doing a thorough physical assessment, especially if it's in an elderly individual. Theories, right? Schizophrenia exists in all groups. Genetic hereditary model is honestly one of the biggest, right? Does schizophrenia run in your family? It's something we have to assess. Stress can cause it. Neurochemical, right? Dopamine. You do methamphetamine. Methamphetamine affects your dopamine. You can go psychotic. Simple as that. We don't really talk about those too much. So, psychotic disorders and the types of schizophrenia. So you have a few different subtypes. I want y'all for this, and let's see if I can switch to it. I did. Look at your book, right? So this is page 372. This is the ebook, right? Catatonic, marked psychomotor problems, immobility or excessive activity with no purpose. It goes back and forth. When we think catatonia, we think someone who's still and cannot move. But it could also be the extreme of that. So catatonia could be someone who is frozen. They're not moving at all. Or it could be someone who is just doing repetitive movements with no purpose, right? Odd movements. That rigid posture is that waxy flexibility. Think Gumby, right? And at least anyone who's older, I know there's a few of you in class who will not know who Gumby is. You can take this person and put them into any form. You could twist them into a pretzel and they will stay in that position. Disorganized, kind of what you think of as more common when we see it, a lot more thinking, speech, and behavior problems. They're just very odd. Paranoid, I hope by this point in time I do not have to explain what paranoid is, right? They think someone's out to get them. They're suspicious, they're hostile. And residual. They have had an episode of schizophrenia, but they don't have the acute psychosis now. So it's a focus on those negative symptoms in residual schizophrenia, right? So catatonic, marked psychomotor problems. They're either unable to move, they freeze, or they move, and they keep going, and there's no rhyme or reason, and they just won't stop moving. Disorganized is what we think of. It's the most common, right? They have the hallucinations. They have the speech and thought difficulties. Paranoid, someone's out to get them. Residual, no hallucinations, no psychosis, but the negative symptom. Switching back and forth now. So, symptoms. Loss of reality is the main definition of what is psychosis. Signs and symptoms affect every single part, right? Perception, the physical appearance, cognitive, language, speech, emotions, behavior, social ability. And it falls into two categories: positive symptoms and negative symptoms. So positive symptoms. The best way in talking to someone today in clinical to remember positive symptoms, if you're walking down the street and you see someone and you're like, oh my gosh, that person looks crazy, I better cross the street. Those are the positive symptoms. These are things you can see. These are things you can hear, right? These are things that a normal person doesn't have that we are now given the person with schizophrenia. So these are the hallucinations. These are the delusions. So, right, going back into your textbook again, they have a very good table 31.4, right? Delusions, hallucinations, speech. Everyone always gets speech and behavior wrong, but speech and behavior are a positive symptom. If you see someone who's staring at a corner and talking to themselves, right? Or you see echolalia, all of those words, word salad, pressured speech, flight of ideas. That is that disorganized speech and communication. Neologisms, right? Those made up words. Agitation, catatonic behavior, still or excessive movement. And then you have the negative symptoms of schizophrenia, right? That blunted affect, the emotional withdrawal. These are the things that pull a person away from society. Right? A lot of those A words: apathy, alogia, avolition, anhedonia. Okay, so delusions, false fixed beliefs. I really invented the electric car and the Tesla. I'm going to sue Elon Musk. I'm going to get all the money and I'm going to live my life in luxury and screw Elon Musk, right? Delusions, false beliefs. The birds are actually drones that are spying on all of us. That would be a paranoid delusion, right? Alterations in speech we're going to cover on the next slide, okay? And then concrete thinking too. Associative looseness. This slide doesn't really describe associative looseness too well. When you go to your textbook, you have a very good table, 31.3, that talks about what all of these are. So focus more so on your textbook. Clang associations, repeating of words and phrases, honey, money, sunny. Concrete thinking, not being able to understand abstract phrases. I once told one of my kids who was jumping around a lot that he had ants in his pants, and he got scared and went to take off his pants because he thought he really did have ants in his pants. He could not understand that abstract thought of ants in the pants does not actually mean you have ants in the pants. Echolalia, repeating back. How is your day going? The person says day going, day going, day going. Or if we tell a patient, hey, it's time for meds, the patient's just going to say time for meds, time for meds. I think everyone has seen flight of ideas, just going from topic to topic to topic. Ideas of reference, we've talked about repeatedly. It's the belief that something is greater. We talked about that guy who stepped on a crack and thought that his mother was in an accident and broke his back because he stepped on the crack. Hallucinations is a little weird. because it gets confused with everything else. It's speech that moves from one idea to another, and it's not related. So flight of ideas and loose associations are really hard to tell the difference, and there's not much. I'm hungry, but the desert has no rain, so it's cold outside, right? But if we look at flight of ideas, the sky is blue, the dog is dead, and I have 2 eyes. They're kind of the same thing. Mutism, not speaking. Neologisms, making up words. I don't even know. You're not ever going to see, I can't even pronounce this one. Pressured speech, that's that water hose, word vomiting. They have to get words out. And word salad is that just jumble of words where there is no sense to them at all. They just say things. So focus on those versus a lot of these things, because there's a lot to it. Circumstantiality and tangentially fall back into that flight of ideas, right? They're going to eventually say things, and they're going to eventually get to the topic and answer your question, but they're going to go off through a whole big circle. Though I really don't like this word, cognitive retardation. Retardation means to slow down, right? This is someone who their thinking is so slowed, you can look at them and you can almost see the wheels turning in their head. You ask them a question and it just takes them a long time to get to it. Thought blocking, stoppage of thought. Usually it's related to hallucinations. They're talking to you and all of a sudden, right, the train of thought stops because they're distracted by the voices in their head. Thought insertion, the belief that someone else is inserting thoughts into their brain. Thought deletion, a belief that someone is taking the thoughts out. The thoughts out of their head. Magical thinking we've talked about, right? Think that their thoughts or actions are affecting someone else. Paranoia, right? Irrational fear. They're out to get me. Depersonalization and derealization we talk about more next week. Depersonalization is kind of a feeling that you're not real, that you've lost your identity, that your body is not really your body. Derealization is the environment, right? So personalization, you're not yourself anymore. Derealization, your environment around you is changing. Hallucinations come in many forms: auditory, visual, olfactory, gustatory, tactile, command. Right? Most of them are going to be based on the 5 senses. Auditory being the most common, hearing voices. Visual, seeing things. And it could be spots on the walls. It could be the walls moving, the pizza cheese bubbling. Olfactory. It's smelling. That was really hard for me to remember what olfactory was. Olfactory hallucinations are going to be smelling odors that aren't there. Gustatory, tasting. Tactile, feeling, right? They're going to feel like someone's touching them. Command hallucinations are especially disturbing and dangerous because they're voices telling someone to do something. And usually it's bad. The voices are telling you to kill yourself, or telling you to go kill someone else, to burn down your house. We need to always assess for command hallucinations, which gets tricky because we also are told don't ask or buy in too much about the hallucinations. But you have to always assess for command hallucinations. Are the voices telling you to hurt yourself or someone else? What are the voices telling you? Right? That was that very tricky question about the birds in the case study, where I just did not like the answer either. But we have to just make sure we're assessing for command hallucinations. Alterations in behavior, we've kind of already talked about at these. Catatonia. Hey, look, it's on a slide again, right? Increased movement or decreased movement. They're not moving at all, or it's just such unpurposeful, crazy movement. Motor retardation. Again, retardation means to slow down. So their movement is slowing. It almost looks like we've put them in slow motion. Motor agitation, excited, running, paced rapidly, right? We call it responding to internal stimuli. Stereotyped behaviors are repetitive. Waxy flexibility, that's that Gumby, right? We can move and adjust them and put them in a pretzel shape, and they are going to stay like that. Echopraxia, mimicking of behaviors. Negativism. You're going to not do what someone wants you to do. Hey, I need you to go to your room. They're just not going to do it. Impaired impulse control. You can't resist your own impulses, right? You're going to just do whatever you want to do and not be able to stop. Gesturing or posturing, right? Sometimes unusual logical expressions on their face. Boundary impairment. You don't know where your body ends and someone else's body begins. So they have that personal space. They will get into personal space and not think twice about it. They will walk up until you are just uncomfortable. So negative symptoms are the absence of human qualities. Anhedonia, reduced ability to experience pleasure in everyday life. Something that used to make you happy no longer does. Someone who really loves art and used to draw and paint all the time no longer does it anymore because it doesn't make them happy. Avolition, loss of motivation. There's no ability, right? They can't get moving. There's no ability to set a goal. Getting up in the morning is hard because what am I going to do? Right? Most of us get up and we have this unconscious list in the head. I'm going to get up, I'm going to take a shower, I'm going to have breakfast, I'm going to do this, 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 and this. That does not exist in schizophrenia because of that avolition. Asociality, without socialness. There's no desire or decrease for comfort from social interactions. So someone who used to be very social no longer goes out or hangs out with their friends. Affective blunting we have in a few slides, but that's the facial expressions not changing. Apathy, just a decrease in interest, right? You just don't care about things that you used to care about. Where this gets confusing, alogia, no speech, right? So the positive symptoms, that changes in the thought process and the changes in speech that we hear are positive, but having no speech is a negative symptom. So when we go back to the few slides, right, that clang associations, the neologisms, the echolalia, they are speaking, words are coming out, they are positive. Alogia right here is no speech at all. No speech is a negative symptom. Crazy, different, unusual speech is a positive symptom, right? So a lack of goal-directed behavior, social discomfort is what makes up the negative symptom. So example we gave today, you have a 20-some-odd-year-old girl whose hair was always done, always dressed nicely, on time, makeup was done, straight A student in, college, had a boyfriend, had a big group of friends, and then all of a sudden she's not hanging out with anyone as much. Her hair's a mess and matted, she's not doing makeup, her room is trashed, she's wearing the same clothes for the last week and a half, right? Those are the negative symptoms. Affective symptoms are our mood symptoms, right? It's the depression, right? Affective is depression, or affective is bipolar, right? So it could be labile, it could be erratic, it could be incongruent, but it's especially dangerous because this can increase suicide risk. And suicide risk is a huge problem in schizophrenia. So, right, negative symptoms, this is that slide with affect. Normal affect, you find out you win the lottery and you're going to be really excited. Constricted affect, your face is going to make some changes. And then a blunted affect, doesn't matter what I tell you, your facial expression is not going to change. Inappropriate and bizarre are kind of just what they say they are, right? Inappropriate, it might be incongruent with the emotional state. I told you you win the lottery and you break down crying. Bizarre is just odd, like it's going to be off. So concrete thinking, we've already kind of talked about. The inability to understand all those little phrases that we have, right? Ants in the pants does, in American, it means you're just running around, jumping around like crazy. But ants in the pants in this situation, to the person, they really do think they have ants in the pants. Memory changes. They can't process information, so it takes them time to understand stuff. And impaired executive functioning. Executive functioning is setting priorities, right? Putting things in a logical order. Okay, if I'm going to bake this boxed cake, what do I have to do first? will let me get out the box, read the directions. I'm going to turn on the oven. I'm going to get out my pan. I'm going to get my eggs and milk. That is too much, right? Even brushing teeth. What do you do to brush teeth? I got to get toothbrush and toothpaste and put the toothpaste on the toothbrush and wet it. They can't put it in a sequence. Okay. We watched this video where it had a bunch of little clips of people with different symptoms. Not going to show that again. Important thing to remember, there's phases of becoming disorganized. So the prodromal phase can be several days to months, even some studies say years ahead of time, where you start to see the decline in functioning. You start to see the emotional and behavior problems. That's the prodromal phase. Then you come up, and your book has it as pre-psychotic and the acute phase, where you start having some of those negative and positive symptoms, right? The negative symptoms come first, and they start getting worse. In the acute phase, you have the hallucinations, the delusions, the positive symptoms, right? Acute phase is hallucinations, positive symptoms, delusions, the paranoia, the strange speech. After the acute phase, it goes to the residual phase. And naturally, even without medications, the psychotic symptoms will slowly start to decrease. But those negative symptoms are going to remain. So the alogia, the anhedonia, the apathy, the asociality. And we go from the prodromal to this pre-psychotic acute active phase, and then from active to residual, but then residual right back to active. So this active residual are going to cycle back and forth. And to have a diagnosis of schizophrenia, this needs to happen for at least a year. So it takes quite some time to get there. Other psychotic disorders. Brief psychotic disorder. There is something happens, a psychotic episode, right? So detachment from reality, that's over 24 hours, but less than 1 month, right? So 24 hours to 30 days. Delusional disorder is having a delusion for more than 1 month. And it says non-bizarre reality-based fixed ideas. So what this means is this is someone who maybe they're not having hallucinations, but it's the person who believes that the birds are actually drones. And the CIA is using those birds that are really drones to spy on them. Right? They just believe this crazy thing is real. A shared psychotic disorder. 2 people have the same delusion. So usually what happens, and there's a really good case of this last semester on Mesquite, one patient was psychotic, was having hallucinations, God was talking to her, the world was ending in 3 weeks. You'd walk onto the unit and she'd be speaking in tongues and praying on you. This other patient was admitted and just immediately bought into her delusions, bought into that psychosis. And next thing you know, she was there and this other guy was following along right behind her, talking in tongues and laying hands and praying too. Shared psychotic disorder. 2 people believe the same thing. Schizoaffective disorder is when depression and mania are also present. So you have the schizophrenia, but you also have major depressive disorder. Or you have schizophrenia and you also have bipolar and are manic. It is not a very good outcome for a lot of those patients because they're dealing with both. So what do we want to happen to these patients? Our therapeutic interventions, right? The goals of that short-term care, so like going to GBHI, is to just stabilize the client. Prevent further decline in functioning. We just don't want them to get any worse. And assist them in coping. It's hard and it's stigmatizing to all of a sudden be diagnosed with schizophrenia. Long-term goals is going to be therapy. They're going to need medications, but also psychosocial and vocational rehab. Their whole life is about to change. So antipsychotics, they slow the central nervous system down, right? After they take these medications, hallucinations, delusions, they all decrease and the thought process changes. So we got the first and second generations, along with the third generation, which honestly just wipe out the third generation because the third generation is a subset of the second generation. And honestly, the third generation is just, I have to get better at flipping these slides, is just Abilify. There are short-acting and long-acting injectables. So when someone gets upset and we give them that good old B52, we're going to give usually 5 to 10 to even 20 milligrams of Haldol, and that is a short acting. However, there are such things such Invega Sustenna, which is a long acting, or the Risperidone has one, Risperdal Consta. There's a bunch of them, and those are a long acting injectable. Person comes every 4 weeks, they get an injection, and that way they do not have to take daily medications. First generation antipsychotics. I cannot tell you how many times we've talked about these, and we're talking about them again. First generation antipsychotics, right? Dopamine. Dopamine is what causes a lot of the hallucinations. And first generation antipsychotics affect dopamine, so they're going to target those positive symptoms of schizophrenia. They're less expensive than second generation. However, extrapyramidal side effects, anticholinergic side effects, tardive dyskinesia, and some waking sexual dysfunction and endocrine disturbances. Right? You're also going to see prolonged QT intervals, urinary retention, tachycardia. Tachycardia is so common with some of these side effects, right? It's just, they're one of those normal. And then you got your anticholinergic. Can't see, dry eyes, can't pee, urinary retention, can't spit, dry mouth, and can't poop, constipation. So when we talk about our extrapyramidal symptoms, pseudoparkinsonism, it's caused by that dopamine, right? We're messing with dopamine over and over. They're stooped over, right? That Thorazine shuffle. They're rigid, bradykinesia, brady, slow, kind movement, slow movement. They're shaking, and that pill rolling. It looks like they have a pill in their hand and they're just rolling their fingers over and over. Acute dystonia. Y'all have seen me make this ridiculously ugly face in class so many times in class, right? Ocular gyrate crisis. The eyes are fixed at the ceiling. They cannot move their eyes down. Muscle spasms, specifically towards the upper body, the back, the neck, and the laryngeal spasms are what makes this dangerous. Akathisia, restlessness, trouble standing still, right? No matter what you do, they just need to move. And they just feel this restlessness. Their feet are constantly going to be moving, and it's not going to make them feel any better. Tardive dyskinesia is, right, involuntary and permanent. Once this happens, there's no going back. Macely, right, tardive dyskinesia, we're going to think face. Protrusion and rolling of the tongue. Sucking and smacking of the lips. Chewing motions, right? Dyskinesia is just weird movements. Right? Dyskinesia means difficulty with movements, involuntary, abnormal, skeletal muscle movements. Right? Definitely take a look at page 379 in that textbook, y'all. There's a lot of stuff on this. Second generation antipsychotics. They affect serotonin and dopamine. Because of the serotonin and dopamine, they're going to treat both positive and negative symptoms. They have less effect on dopamine, so minimal to no EPS or tardive dyskinesia. So those movement symptoms are lower. However, they tend to cause weight gain. But the important thing to keep in mind with these, right, your slide list, Clozaril, along especially with some of these, all of them, but especially Clozaril, it's like 20% of people have a risk of agranulocytosis. Without, granulocytes are a type of white blood cell. Agranulocytosis leads to neutropenia. Neutropenia, right? Your body doesn't make enough white blood cells. It cannot fight infection. So neutropenia is life-threatening. We have to monitor our patients for being sick, right? Low-grade fevers. As much, your patient comes up complaining of a sore throat, we are going to be extremely concerned. Third generation, that all kind of gets mixed in. Right? It's really just Abilify. They kind of do the same thing as the second generation. Okay, so here, neuroleptic malignant syndrome. Haven't talked about that again yet, though I know we've talked about it in class. It's a sudden high fever. Increased heart rate, increased temperature, increased respiration rate, right? Change in mental status in neuroleptic malignant syndrome. Their muscles are rigid. Now, agranulocytosis, we just talked about that again. Right, they're going to need frequent lab draws, at least monthly, if not more than that in the beginning, because of the risk of agranulocytosis, which is a type of neutropenia, low white blood cell, high risk for infection. So to tell the difference between neuroleptic malignant syndrome and agranulocytosis, if you were to see this like on the NCLEX or something, neuroleptic malignant syndrome has the high temperature, right? And changes in mental status and neuromuscular rigidity. Agranulocytosis, honestly, we're going to be concerned if they're just sick, right? This is where like we might get concerned about a 99.8 degree temperature, even though it's not a temperature, along with complaints of a sore throat. I woke up and my throat really hurts and I have a headache and, well, 99.8 isn't really a temperature, but in a patient who can't fight an infection, we want to make sure that it is not the start of something more seriously. Anticholinergic toxicity, we've kind of talked about this repeatedly, mental status changes, right? It can be, you can think that this is hallucinations getting worse. Nursing therapeutic process, we've talked about these nursing diagnoses, right? Disturbed thought process, social isolation, impaired communications, right? And the basic goal is to assist all clients to get to their highest level of function possible. So what are our responsibilities as a nurse, right? Talk about medications. Why? What are the side effects, incompatibilities? Monitor to make sure the client's doing well. And we have to educate sorry, y'all, I guess my battery's running low. We have to educate the whole family, right? Discharge planning needs to include medication. Not taking medications correctly or not understanding the need for compliance leads to relapse in symptoms. That is it for the slides. Again, your text is actually really, really, really good. Going over all of these things briefly, right? What's in the medications? What are our interventions? What are all of these two, right? Bradykinesia, slowing of the body. Akinesia, absence. Dyskinesia, involuntary abnormal skeletal muscle movements. So we've talked about a lot of this stuff over and over and over again with schizophrenia. So make sure you review this. Make sure you review even that PowerPoint that I posted and that video on antipsychotics, because all of those are fair game on this test. If y'all have any questions, please reach out.